Hi, I'm Ruth Fein. I'm an MPN patient with myelofibrosis. I've been living with one form or another of an MPN for nearly 30 years. And when I was first diagnosed, that was in the 90s, MPNs weren't even called a blood disorder. So what I went through in diagnosis is very different than what's happening today, where the initial diagnosis is that big C, which of course is a fear that I didn't have to deal with. So I didn't have to deal with the fear, but now with myelofibrosis, it's a game changer. I'm very fortunate, as we all are, that research is moving so rapidly, changing our prognosis as the research advances. In fact, I'm on a clinical trial almost 3 years now. So I remember it really clearly. I was in New York. It was supposed to be a routine appointment. It was pouring hard with rain. I was soaking wet. I was carrying around my luggage, and I sat down for my appointment with my super MPN specialist. And I had had a bone marrow biopsy that surprised me, and I had a new diagnosis. All of a sudden, I went from ET to PV to myelofibrosis, and that's the dreaded myelofibrosis. Out of the MPNs, that's the progression that people are worried about. So I felt immediately shocked, and then 3 hours later, I felt completely comfortable, and she said, "I have the perfect clinical trial for you." I got all of the information, decided it made sense for me, and that was 3 years ago, and I am doing incredibly well. So it's not just about feeling well, it allows me to be me. I'm still gardening. I'm a health and science writer. I garden. I walk every day. I cycle. I swim. I'm the mother of two adult boys and a wife of a very active, wonderful man. And my life is very full. And I happen to be a patient with myelofibrosis as opposed to my life being about myelofibrosis. So there's so much that we can do as patients to ensure that we're getting the best care that we can to help us live longer and to live well as long as we're here. And that's why we have these conversations, so we can bring to you the expertise and the collective wisdom of the super specialists in the MPN world. So today it's all about MPNs and specifically myelofibrosis. We're here with two incredible docs who are lending their insights so that you can take your questions to your own doctors. And we have with us today Dr. Serge Verstovsek with MD Anderson. He's the founder and director of the largest MPN clinical research center in the world. And Dr. Naveen Pemmaraju, also with MD Anderson, who's the director of its rare disease program and executive director of the Cancer Network. By the way, we're having this discussion coming out of the biggest meeting of the top blood cancer and MPN specialists in the world. And our goal is to highlight what's likely to be most impactful for those of us dealing with myelofibrosis, both patients and caregivers. Stay tuned, because at the end, we have some promising data on a therapy that could potentially not just address myelofibrosis symptoms, but eliminate the disease for some of us. And that's very early, but it's exciting, as it was picked to be one of just a handful of highlighted sessions out of thousands at this conference that just wrapped up. First, let's set the stage for people watching this. Most myelofibrosis patients and care partners go to a community care center. That's, of course, where I started for 20 years. Even if a lot of what we're going to talk about today is still potential or in clinical studies, what are the questions that patients and caregivers should be asking? And how would we even know what those questions are if we didn't have conversations like this with MPN specialists?
First, to thank you very much for having me on the program today. Thank you very much. It's a pleasure to share excitement with you. And a little proactive approach is always a good one. First is, of course, to learn about the condition and the disease and see how the treating doctor is about providing the answers. It's a team effort, no? And nobody knows everything. Be mindful of that. And then, if necessary, go for a second opinion to the MPN specialist, because ideally there would be a team, a local doctor, the MPN specialist, and the patient who decide what to do at what time. The patient is actually in charge, right? We are only suggesting. And so being an advocate for yourself, because it's a lifelong condition, which has a potential to shorten the life. That's why I'm saying be advocate and engage, and don't be mad or or said, there is a lot to do together with the local doctor, with the MPN specialist, and ask questions. If there are no answers, seek the answer, and be one of the contributors altogether to improve your own condition. That's I would say, be active participant, and as I always say, just mentioned it, who is the decision maker? It's the patient. And so the educated patient, engaged patient is the best patient.
Great tips, Dr. Verstovsek. You've been leading the way in MPN research for decades, as many of us know. And it seems there's been so many developments in terms of cutting edge treatments and new therapies for myelofibrosis. What do patients and care partners know about that?
You're right. There is a lot going on in the MPN field. And I like to divide this to excitement about what's coming soon and what's coming maybe not soon enough. Back 2004, when I really engaged in MPN, there was no standard of care and there was no study or studies. So we were trying to seek friendly people in different companies where we would perhaps use the drugs that are already on the market for something else, like a thalidomide or lenalidomide. People probably resonate well with these drugs. We tried them, and other colleagues in the field tried them in myelofibrosis, and they do help, but not too much and not too often. And then the discovery of the abnormalities, the JAK2 and others, led to real interest in developing more specific drugs for myelofibrosis. Where we are now, it's like a day and night. Now there are 3 approved drugs for myelofibrosis, 4th one maybe, momelotinib next summer, so 4. And numerous phase 3 studies, numerous studies in general that you have options, and we just seek more patients' participation.
Thanks, Dr. Verstovsek. Let's dive into what many of us at home know more about, and that's JAK inhibitors. We have 3 FDA-approved ones right now, right? There's ruxolitinib, which is Jakafi, fedratinib, which is Rebic, and pacritinib, which is Vonjo. There was an update on that last one, pacritinib, for myelofibrosis patients, and love you to share a little bit more about that one.
This is the JAK inhibitor that decreases the spleen, improves the quality of life, and it was approved in February of 2022 for patients with low platelets below 50, because it does not suppress the blood cell count, unlike ruxolitinib or fedratinib, the other JAK inhibitors that are already for quite some time on the market. The novelty from this ASH 2022 is that it can improve the anemia in some patients, and that appears to be added value to it. And I actually tell my patients that I treat with pacritinib that, and these are ones with the lower platelets, that look, it's not going to suppress your blood cell count. It may actually improve the anemia, and it is good for the spleen and symptoms. So there is added value now that we know of, with very well description of that value at ASH 2022. That's on the recently approved drug. But much enthusiasm is about a JAK inhibitor called momelotinib, which will be likely approved by the summer 2023, because the application was submitted and it's under review by FDA. This particular drug, it's a pill, like all the other JAK inhibitors, is different. It may improve the symptoms and the spleen, like all the other JAK inhibitors, but the real value is that anemia benefit. That is the primary reason why would you use the momelotinib, because in a phase 3 randomized study that was done during the COVID era, actually, quite amazing, it was proven to be very valuable for patients after initial ruxolitinib for control of the anemia, improving the symptoms, improving the spleen. So we expect that momelotinib, which is also very safe, all of this came from the ASH 2022 analysis, and is durable, that will be one of the major new drugs, particularly in the second-line setting, once people fail ruxolitinib. So we will have then choices. We would have pacritinib for people with low platelets, momelotinib for patients with anemia. We would perhaps optimize our care of patients for a longer period of time, because until this year, we have been limited. in what we could do once the JAK inhibitor number one, the ruxolitinib, fails.
I particularly hope, and I know all my colleagues do too, is that we have dozens of these drugs to be able to offer to different patients. And hopefully one day we have a biological molecular approach to selecting them as well.
So Dr. Pemmaraju, let's move to another big headline. That's combination therapy, which we hear so much about. And we know it's the next focus, or the current focus, in treating myelofibrosis patients.
Combination therapy in not only the relapse refractory setting, but also now investigating it in the frontline setting. But we have to keep in mind, how is the patient tolerating it? Are there too many side effects? And then what is the actual benefit of adding the second agent as compared to the JAK inhibitor alone?
This always goes back to the story of not all patients are alike, right? There's not a cookie cutter approach to MPNs. In fact, I like to say that the only thing we can count on with MPNs is that we can't count on them. They're not predictable, right?
We always talk about personalized, individualized, targeted therapy. Well, this is the era that we're in now. Each patient may have a different comorbidity profile. That means other diseases and diagnoses that they carry outside of the myelofibrosis, different ways they metabolize drugs, different molecular mutations in their myelofibrosis. So we're in a whole new era of trying to select either clinical trial drugs or hopefully one day even standard of care drugs based on what you said.
Thank you, Dr. Pemmaraju. Let's talk about some of these combinations. So one update has been on BCL inhibitor, navitoclax, in combination with a JAK inhibitor. Where would that come in?
Yeah, this is excellent. And of course, for all the viewers out there, many of whom are familiar with me, I think the navitoclax agent, BCL-XL, is important. It's not yet FDA approved for anything, but what it's showing is that in myelofibrosis in particular, either as a single agent or in combination with JAK inhibitor, that we published together, that it has possible disease-modifying effects. So we showed a very good overall survival in suboptimal patients who were already on a JAK inhibitor, and you added the navitoclax, some variant allele fraction reduction, some bone marrow fibrosis improvement. So the navitoclax agent is now in what's called phase 3, so the later stage randomized global study, ruxolitinib plus navitoclax versus ruxolitinib alone, essentially. And we hope to have those results in the coming years so that we can know if the combination approach is beneficial to our patients in the frontline untreated setting.
Okay, I want to talk about another phase 3 trial, a drug close to my heart, pelabresib. That's the trial that I've been on for 3 years. And that's used again with a JAK inhibitor. I understand the results have been very promising. And in fact, my doctor calls me a poster child for this clinical study.
Yeah, exactly right. So in this class of combinations, we mentioned the BCL-XL strategy, navitoclax. You also have this bromodomain or BET inhibition with pelabresib. Very encouraging results there as well, which again started out in the single agent relapse refractory setting and then was added on to the ruxolitinib and now is being investigated in patients. Again, same thing, phase 3 randomized study, frontline. For you and I that have been in the field for longer than a decade, what this marks is for the first time we're moving combinations into the frontline setting. That means a patient who's newly diagnosed with myelofibrosis to then put forward 2 drugs instead of 1. That's the big deal here, and we're starting to hear those results.
This is really exciting, right? Because we're talking about options here. You already went over this very well, but if you were to say anything more as a specialist, a super specialist in myelofibrosis and other MPNs, here you are seeing a patient and you're making decisions on which way to go with therapy. What other considerations are there since you have so many options now, thankfully?
Well, there is more. And more means that perhaps there is no real reason to switch right away. If one thing doesn't work, maybe you can optimize it. What does this mean? This means that you can combine things together. Now, there are a number of medications which are not JAK inhibitors that are active, improving the red blood cell count or improving the spleen or symptoms in myelofibrosis patients, that can be combined and being tested in advanced clinical studies to help the patients right from the day one. Meaning if the patient needs therapy, newly diagnosed, why don't we use 2 drugs together instead of 1? So there are medications like pelabresib or parsaclisib or navitoclax or luspatercept. Funny names. Nobody really needs to understand their names, but what they are to do, basically given for, is to enhance what the JAK inhibitors do. More of the spleen, more of the symptoms control, and perhaps durable, much more durable. Or in case of luspatercept, that's one is for anemia control while you are treating with the JAK inhibitor ruxolitinib. That's one aspect of the drug development, starting with the best combination from the day one. Or if you start with the ruxolitinib alone, you add in suboptimal responders, people who benefit but not optimally, you add another agent a little bit later. That's like a parsaclisib, another daily pill that was proven in a presentation in ASH to be very valuable in people who are already on JAK inhibitors, doing okay, but there is room for improvement. You add parsaclisib on top of it, another pill, and you enhance the spleen and symptom control. So not necessarily that we need to go from one drug to another drug to another drug, which is the common path, and it's always there to do. Maybe we need to talk about combinations in specific clinical situations, and we are developing multiple different combinations for different clinical scenarios. One will be better than the other or applicable more in one patient than the other. And if that doesn't work, you go to another drug and then maybe another combination. So we'll maybe within next 3 to 5 years have a number of choices, not just as a single agent, but the combinations, combos.
So how do you decide which combination to try first? I know there was data also presented on ruxolitinib with other different agents, some of them also novel agents, such as selinexor. And that was first approved in multiple myeloma. Now it's being used in myelofibrosis treatment research. Can you shed some light on that?
Yes. So we have been studying several combinations already. I mentioned those medications, but there are newcomers, which may be better. Difficult to say from the beginning, but selinexor is another drug that is approved for multiple myeloma, which may be active in myelofibrosis. It seems so from the preliminary results. Interestingly, there was also a presentation by Dr. Kilajian from France on adding interferon to ruxolitinib, which also enhanced the ability of ruxolitinib to do the job on the spleen and symptoms. And there were some intriguing results on molecular improvements as well. So perhaps it's not only about combinations with a completely new, unproven yet, or completely investigational drug. Sometimes you may just look a little bit back in time and say, is there something there that I can use that is already established as agent or a drug, interferon, right? So we are kind of having a larger umbrella here without limitations in our attempts to optimize the care for our patients. And so it's pretty exciting. I mean, you can have that selinexor as an example. You would think that's approved for something else so much different, myeloma. Well, you try it in a completely out of a common sense approach like myelofibrosis, and it does work. So we'll follow that particular combination, clinical study of that combination very carefully as well.
There's this new era of these novel drugs. They either come straight out of the lab or they're borrowed from some of the other blood cancers. So the selinexor you bring up is a novel one. It's actually already US FDA approved, for example, in multiple myeloma, but sometimes the doses are higher or lower, mechanisms of action, combinations. And so again, that combination, that new drug is following the same pattern we've seen, which is single agent activity first, relapse refractory, and then now moving into the front line in combination with ruxolitinib JAK inhibitor.
One other area of inhibition, if you will, you mentioned these different kinds of inhibitors, including kinase inhibitors. That's something else that could be just over the horizon, right?
Yes, exactly. And so a third category outside of these two is what's called PI3 kinase inhibition. So kinase, the word itself, when it's used, really means messenger or pathway in some of these cancer cells. But as you mentioned, what we're starting to do now, and again, we didn't have these clinical trials 5-7 years ago, is picking out individual pathways in the cancer myelofibrosis cell outside of JAK-STAT trying to pick pathways that may complement JAK-STAT so that you can get a dual or combined approach. That's what a lot of these phase 2 and phase 3 trials are doing, and even more novel agents than these first 3 that we're talking about.
One important point, too, is how frightening the prospect of a transplant can be, and of course ought to be. Do you feel that some of these newer therapies or combinations will help alleviate the need to go there at all?
Well, I think it's actually at the moment, it's the other way around. We are trying to improve the condition of the patients and make them physically better, metabolism to improve, inflammation to be controlled well, and get to the patients to a transplant in best possible shape, because at the moment, transplant is still the only procedure that can eliminate disease and cure the patients. There are limitations on the medications. We are trying hard to extend the benefit of pills, but they have limitations. Nothing really works forever. So I hope that there is actually more patients going through the transplant as we improve their condition. And then the transplant success is even higher when you get quote unquote healthier patients, right? Unless we develop the drugs like we started discussing at the beginning, something that would potentially eliminate disease, antibody in the calreticulin mutated patients, but this is in the future. It's not even in the studies yet, has that potential. So at the moment, we encourage actually people to go through the transplant when they are in best possible shape on a JAK inhibitor.
Allogeneic stem cell transplant remains the only curative modality for our patients with myelofibrosis. It's tough to say that because it's such a difficult procedure for many of our patients. Many of our patients are older, comorbidities. Across the world, as I meet with patients and doctors, they don't have access or follow-up for it. So that's tough. So that's the hope and optimism that I personally have, is that can we offer these combinations or other novel agents to try to cure the disease outside of the stem cell transplant. So yes, unfortunately, I would say stem cell transplant is the only curative option, but again, unfortunately, it's not available to the vast majority of our patients.
So speaking of a cure, that is the big splash that just came out at the ASH meeting. That's the American Society of Hematology that we've been speaking about. Dr. Verstovsek, what was all that buzz about?
And it has to do with the development of a possible new therapy. The keyword is possible because the presentation was on preclinical testing. Possible new therapy for a third of the patients with myelofibrosis or ET that have a specific mutation, so-called calreticulin mutation. Now, everybody probably knows about the JAK2 mutation, but there are a couple of other mutations that are important, that are mutually exclusive. So you have JAK2 mutation, calreticulin mutation, and MPO mutation. These are mutually exclusive and present in about 90% of the patients with myelofibrosis and 90% of patients with ET, essential thrombocythemia. And what they do is they activate inside the cell, bone marrow cell, this pathway that we call a cascade of protein. My patients call it a highway, a JAK-STAT highway. It's always active because of these driver mutations, right? So that makes the cells grow and that causes inflammation. So you have proliferation and inflammation. Because this mutated protein is on the surface of the cells, we can identify malignant cell. This is a marker of malignant cell. And now the presentation was on development of antibody, another construct that would be attaching specifically to the cell with the mutated calreticulin and basically let it die off over time. So elimination of the disease. This is a potential of such a therapy, antibody for mutated calreticulin, which will be given to patients with myelofibrosis or ET that have calreticulin mutation by genetic testing. It's easy to do. And that the potential of inhibiting the growth of malignant cells specifically and elimination of the malignant clone is what everybody is talking about. So we hope that in near future, perhaps within a year, 2023, we'll have a study of it with the antibody for patients with calreticulin mutation. Extremely exciting, I tell you, because we usually talk about improvement in the bone marrow function, like anemia needs to improve or decrease in the symptoms or smaller spleen. This has a potential of what we call molecular response, decreasing the number or eliminating potentially the malignant cells.
Speaking of clinical trials, as I mentioned, I'm in one. It's been 3 years, and I know that something close to all of our hearts is getting more people to know about the clinical trials, and ultimately a more diverse and larger numbers of people participating, right?
Yeah, and the participation in the study then would be the ultimate goal, in my view, from the patient perspective. You get the standard, but you get something extra on top to make it even better. And so why not, from your own perspective and from the perspective of benefit to the community of MPN patients, why not seek participation in a clinical study if it's not mentioned already by the treating doctor?
That's exciting because it helps people also understand the importance of where all cancer therapies are headed, right? Or hopefully headed, understanding more about the data about every individual patient, and in this case, the mutation. What's your message to patients and caregivers about the importance of making sure they understand and they ask about mutations?
The best patient is the educated patient. So we, in our own practice, try to provide to the patients everything we know about their condition, unless the patient says, no, you are the doctor, don't tell me anything, which is not very common. We have a very enthusiastic group of patients that would like to know everything and be part of decision-making and planning, which is the optimal care, in my view. So we embrace everybody and we want everybody to participate and understand, including what you're asking about. You know, the disease is there for some reason. We cannot really say this is why it happened, but we can describe it very well by molecular testing and the testing of chromosomes and the testing for fibrosis grade in the bone marrow. And as you measure the spleen and the red blood cells, the same way, you want to know everything you can. And sometimes that information is useful for therapeutic decision-making. Sometimes it's not. The patient education and understanding of what is it and what can we do about it and how is very important. So look, calreticulin mutation in the future, potentially, some reservations here, can really make a difference for these patients. We'll see.
It seems that two things are going on, right? One is medical science moving at lightning speed, and personalized medicine being the name of the game today. So patients need to have an active dialogue with their care team to see what's the best treatment options for them and what clinical trials might apply to them. And tell us a little bit more about how you encourage patients when you're speaking to them.
Yeah, you could not have said that better. I really want to emphasize what you said, because we are beyond now the point where we only had one treatment option or one standard of care option. So that's awesome.
I always try to emphasize to our colleagues in the field and the patients themselves who are savvy and go online that there is so much going on. Get engaged. Standard of care came to become standard of care from research. It didn't just appear. And so the combinations or the new drugs that are in development, potentially better than the standard of care, again, are subject to research. That's how you do it. And so we are here to team up with the companies, with the regulators, and with the patients all together for a betterment of therapy for myelofibrosis. So be alert. It's a lot is going on. Be participant.
Thank you both, Dr. Verstovsek and Dr. Pemmaraju, for joining us today. You've helped myelofibrosis patients and care partners a lot, not just today, but in all the good work that you do.
Thank you so much, and thanks for having me on today.
My pleasure. I hope it was useful to everybody. Contact me anytime, any patients, please. I'm here to help, and I'm looking forward to future interactions with you. I hope you have a nice 2023.
And thank you to the patients and the loved ones, those of you who are so engaged in understanding more. There's a lot to be hopeful about. I like to call it fact-based hope. I'm Ruth Fein with The Patient Story, and take good care.